In this video, we are going to discuss the condition toxoplasmosis. I'm calling this the 2.0 edition because I have another video that I recorded earlier on toxoplasma, which is the organism that causes toxoplasmosis, that I'm not going to take down, but I'm re-recording it to provide kind of an update and kind of give it the same information in a little bit of a different style. So the organism that causes toxoplasmosis is Toxoplasma gondii. There's really only one species, but there are many serotypes of it. So you can find other ways of differentiating the different Toxoplasma gondii serotypes. So there are, small mutations, but there's really only one species that is causing disease in humans. Obviously, if you dig into the literature, you'll find some information about the different serotypes. So something to keep in mind. But largely, we're just going to talk about all of the serotypes as one species of Toxoplasma gondii that is causing disease. So toxoplasmosis is the condition caused by infection with this guy. He's a protozoan coccidian parasite. So what does that essentially mean? It's a single-celled parasite. Since it's a parasite, it's a eukaryotic organism. So it has, normal organelles and cell membranes just like we do. It's typically transmitted by the consumption of contaminated food and water, and therefore it's typically spread via the fecal-oral route. But there's kind of an interesting thing. So normally when we think about contaminated food and water, we think about it, in areas where clean water is not accessible. That's not always the case with T. gondii, because T. gondii is a parasite. It has a very specific life cycle, which we'll talk about a little bit more. But one of the things that's absolutely imperative for T. gondii to reach its infective form is time within a feline host. That's right, cats really are trying to kill us. And this time they're doing it with their feces, because essentially the infective form will be in the feces. You go to change your cat's kitty litter, you forget to wash your hands before going and preparing some food, and you have toxoplasmosis. So it's one thing to keep in mind when thinking about whether or not you want to make the decision to own a cat, but also how it is contracted by us. It requires, beyond just the feline, it also requires an invertebrate host for a period of time, an arthropod. So this essentially just tells you that it's a zoonotic parasite, that it can infect multiple different species at a time. Prevention is focused really on sanitation, hygiene, and vector control. So if you can avoid the vectors and keep them down and keep things clean, you're going to be fine. In immunocompetent people, this one is normally pretty minor, no significant disease, but really who we worry about are immunocompromised patients and neonates. Okay, so as I said before, T. gondii is a coccidian parasite. All coccidia are microscopic, spore-forming, single-celled, obligate intracellular parasites. So that tells you one thing. It's obligate intracellular. It means it has to go inside of our cells at some point. So when it does that, that tells you that cell-mediated immunity is going to be really, really important in combating this parasite. So that's why we worry about neonates, the elderly, the immune-compromised, and pregnant women, because those are all classes of people who tend to have deficits in cell-mediated immunity. We have talked about some other coccidian parasites. So for example, Cyclospora and Cryptosporidium, those are both examples of coccidian parasites. So those microscopic, spore-forming, single-celled, obligate intracellular parasites. T. gondii itself is found in a wide variety of animals, birds, humans, all sorts. Like I said, there's only one species. While they might identify different genotypes and serotypes, there's really only one. And there's very little variation in these strains, so we can kind of just talk about them en masse. As part of its life cycle, it's absolutely imperative it spend time in this cute little guy who really is out to get us, because he is going to be what is most likely to transmit it to us when we have indoor-outdoor cats that we spend a lot of time with. The common house cat and other felines are a significant concern because it needs time in the intestinal tract of the cat to fully develop and release its oocysts in the feces. So humans typically become infected from two sources: ingestion of improperly cooked meat from animals that serve as intermediate hosts, carnivores or herbivores, so for example, hamburger meat, and birds. So that's another pet that I will never have, is birds, because I feel like they are just rife with disease, and it's how bird flu will start. We'll talk about that in a different video. The other way is ingestion of the infective form. The infective form are the tachyzoites or the oocytes. Tachyzoites, trying to write it out clearly so you guys can actually read, or the oocysts. We typically ingest these when they are passed through in cat feces and then are not properly cleaned from our hands before consuming something. So T. gondii develops in the intestinal cells of felines and then is spread to the tissue via the bloodstream. The organisms are then going to pass out of the cat, where they mature into infective cysts within about 3 to 4 days. Then they're transmitted via the fecal-oral route to other animals, like us. They're going to produce an acute or a chronic infection in a wide variety of tissues, which we'll talk about in a minute. But some of the main ones are the brain and the eyes. Those are places where we actually expect to see it. Infection in cats is established when the tissues of infected rodents are eaten. So the cats are going to go, and Tom and Jerry style, go and kill this mouse. The mouse already has it, so the cat actually ingests it as well, just not fecal oral. In this case, it's ingesting the mouse meat, and that meat contains the parasite. Okay, so after we ingest the infective form, which again, the infective form is the tachyzoite. This is also the diagnostic form. So remember, the tachyzoite is essentially a slender, like crescent shaped organism. So the parasite is just kind of looks like this little scythe, almost like a corner of the moon. The disease-causing form, though, is actually what comes later, and that's actually the bradyzoite. The bradyzoite actually undergoes rapid multiplication from the tachyzoite, and it forms an initial infection in the tissue and damage. And then you have this slower growing, shorter form, the bradyzoite, which develops cysts in chronic infection. So you can have tachyzoites that are replicating rapidly, causing disease, but then you can also have them develop into the bradyzoite, which leads to chronic disease. So there are a couple different types of disease then. So most T. gondii infections, it's important to note, are going to be benign and asymptomatic in the immunocompetent host. Most of you watching this, if you contracted T. gondii, probably wouldn't even know you had. In immunocompromised hosts, though, symptoms will occur as the parasite moves from the blood to the tissues, where it's going to become an intracellular parasite. So the first thing we're going to talk about is acute toxo. In most patients, where it's asymptomatic, we don't worry about it. But in some patients, you'll have these initial presenting symptoms of just kind of undifferentiated fever. Nonspecific, you'll get chills, fever, headache, myalgia, lymphadenitis, and fatigue. And then you'll get better, and it's not a big deal. In some cases, we move on to chronic toxo. All of the same symptoms that are seen in acute, in addition to rash, liver involvement, as shown by evidence of hepatitis, encephalomyelitis, and myocarditis, are all on the table. In some cases, we also see chorioretinitis, because it does seem to have a preference for the brain, which is why we get meningitis, and the eyes. So those are two things that we worry about. So obviously meningitis is often fatal, so we're concerned there, and the chorioretinitis often leads to blindness. When we are most concerned about it is these two cases, though: congenital and reactivation. So we get congenital toxoplasmosis during basically in utero. So you'll get transplacental infection. So it's able to cross the placenta and affect the infant. Either from infection acquired from meat and meat juices or contact with feces. You can get it either way during pregnancy. The infant may appear to be asymptomatic at birth, but what happens is you essentially deliver this, seemingly completely healthy brand new baby. And then within a couple of months, sometimes years, the infant starts to develop issues. So chorioretinitis with or without blindness or other neurologic problems. Most often, children develop chorioretinitis, but we can see other things. If the infant is infected during the first trimester, the most likely outcome is spontaneous abortion or stillbirth. So the most likely outcome is death. In some cases, though, the patient is still born and we just see severe disease. If it's in the second or third trimester that the infant becomes infected, then we see things like epilepsy, encephalitis, microcephaly, intracranial calcifications, hydrocephalus, psychomotor or mental deficits, chorioretinitis, which essentially leads to blindness. You can also see other things like anemia, jaundice, rash, pneumonia, hypothermia. I mean, really, at any point, you can see kind of these really random congenital abnormalities as a result of infection of the infant in utero. So the other population that we worry about are kind of the immunocompromised. And in them, we're most concerned about what's called reactivation toxoplasmosis. This occurs in older patients, and then also is a big concern for the HIV and AIDS community. And in this case, essentially you have kind of latently growing bradyzoites in the patient. So we call it latent toxoplasmosis. And essentially you have presenting symptoms of Toxoplasma infection of like neurologic symptoms. Most frequently you're going to see like a diffuse encephalopathy, some meningoencephalitis, or cerebral mass lesions. When this happens, it's often very hard to fix and hard to treat. So normally what we're doing is when we have a patient that is HIV positive whose CD4 count gets below about 250, you start checking them for serology to diagnose things like Toxoplasma gondii so that you can put them on the antiparasitic before they have a problem. So disease is typically associated with AIDS patients, but we've also seen this in other patients, particularly those who have undergone a solid organ transplant. Okay, so how are we going to diagnose it? Diagnosis is actually a little bit tricky. So for one, we can't culture it, and culture is often our gold standard. So our gold standard is automatically out the window. We can biopsy it, theoretically, and look for those tachyzoites and cysts, right? But oftentimes we're looking in the brain. So a brain biopsy is kind of a rough first step, right? You could take a biopsy of the lymph nodes, brain, myocardium, CSF, amniotic fluid, or even do like a bronchoalveolar lavage, depending on the patient's symptoms, to look for this, but that's pretty intense. So we have a couple other options. First off, you can do serology. Serology it's important to show an increasing IgG or, because it's a parasite, IgE serology. Presence of these antibodies can be helpful. Now, there's a caveat though. Once you have these antibodies, you always will. So just presence of the antibody in a single specimen is not diagnostic. What you need to do is take the serology, you need to take serial serology samples so that you can actually show that the titer is going up, and that's more indicative of an active infection. I'll also say, let's say you do serology and you find IgM for T. gondii. If your patient is pregnant, which is one of the major groups that we are worried about, this is completely non-diagnostic. Pregnant women seem to have higher titers of a lot of different IgMs, so it's really not all that useful. The other thing you can do is a T. gondii serologic profile, or a TSP, which is essentially what I'm talking about here. This is used by specialized reference laboratories. So essentially you'll take your serology series and you'll send it to them. And the TSP tests for antibodies to determine if infection is consistent with recent acquisition or prior exposure. And that's going to look for IgG, IgM, IgA, and IgE. But again, if you're dealing with pregnant women, take that IgM with a grain of salt. You can use CT or MRI, particularly if you're worrying about CNS involvement. So you can look for specific lesions as a result of that. You can also do ultrasonography, amniocentesis plus PCR if you're worried about the fetus. So in that case, serology is not going to be all that useful because maternal IgG will be present, but you can look for specific changes in the newborn and PCR for the organism itself there. Okay, so how are we going to treat it or prevent it? First off, most of us are never going to worry about it. For most immunocompetent patients, this is not going to be a problem. In the HIV and AIDS or immunocompromised community, you might want to do some prophylactic treatment. Typically, that surrounds pyrimethamine sulfadiazine, which you're going to do at high doses for 4 to 6 weeks before switching to a low dose, pretty much indefinitely until their immune system rebounds. If you are dealing with CNS toxo, you might need to use trimethylsulfa. But one of the issues here is that one of our prophylactic treatments is pyrimethamine. Pregnant women can't have pyrimethamine because apparently it's teratogenic. So really, we counsel pregnant women to just avoid it altogether. So the best way, which I think is just a good rule of thumb for life, is to avoid cats. But if you can't avoid cats, avoid handling raw and undercooked meat and make sure that you're practicing good hygiene. Thanks for watching.